This is Dr. Abbasi. We are talking today again about the correction of scoliosis in a minimal invasive fashion. Here we are talking about the 80-year-old male with degenerative scoliosis. Patient had for years symptoms, and after failing conservative therapy, obviously we did a thorough investigation which showed, as you see in the CT, quite significant scoliosis and degenerative changes. As a matter of fact, the cup angle is somewhere between 15 and 18 degree, depending on where you measure it, between the L3-5, as well as you see in the MRI, in certain area actually can be even somewhat worse. Now, here we are dealing with the multi-level degenerative changes, and the first response would be to do a thoracolumbar fusion, but upon a very thorough investigation, we noticed that most of the symptoms actually correspond to L3-5. If you look carefully in the CT, we see that there is a autofusion and the foramen is open and stable. And considering that we are dealing with the 80-year-old and that most of the symptoms correspond to L3-5, we decided to do a limited surgery in the L3-5 with the OLLIF. And it's important as well to look at this picture. We see the extent of the osteophytic changes, both anteriorly as well as in the lateral aspect. This is the left side, obviously, and it will be difficult to enter this disc because of the osteophytic change. As you see, it turns up, and in the operative changes that in the operative pictures that we took today, I'm going to show you how it looked like in the surgery. But just looking at that and going through the thorough investigation, we thought it's appropriate to just address a segmental level between the L3 and L5. And again, we are dealing with the autofusion and practically no symptoms from 5S1 and very little or no symptoms from L2-3. So in the sense of treating the patient and not the pictures, we decided to do a limited surgery. Now, I'm going to put a picture of the surgery on now, and let me go to the beginning of the surgery. Here you see that this is the spinal needle for the marking. This is the probe, and here, if you look carefully, you see that we are at the osteophyte, and the K-wire doesn't want to go to the disc base because practically those osteophytic changes that we saw doesn't let the K-wire enter, and you see it goes around it, but with some care we could get it in. And now if you look at this, you see that disc base gets opened, and practically with the same action the foramen opens up. Now when we put the cage in, you see the K-wire, the disc preparation is done, and here is practically after we put some of the K-wires in the pedicles, we go to the next step, and again here it was difficult to get into the disc base, but with some care we could get there. And here again you see how the disc base opens and the scoliosis practically get corrected. If we would measure the cup angle here, we would see that practically this is less than 5 to 3 degree, and the disc base is distracted. In the this view as well, I think here's the final picture in the AP. In this view as well, is important to know that patient had a previous laminectomy, so the landmarks are extremely hard to identify. Here the spinal process of one of the upper level but then here you would want to think that this is the spinal process, but I think actually this is the remaining part of the spinal process, the laminectomy, and these are difficult pictures to interpret for interpretation, but I see remnant of the lamina here, and pedicles are okay in few places, but hard in other places to identify. So this was actually a pretty difficult case to do because of the laminectomy. The landmarks are hard to identify. Here is the lateral view. Again, at this point we are already on the osteophyte. If you look carefully, there's still a distance, but I can assure you I was on hard bone, and now I'm entering the disc space, and again look at the opening that happens when the distractor and the dilator is entered, and the disc is now worked on and the cage is placed. Now let's go to the next step. Here again the K-wire goes in, and if you look carefully here, you see how the disc base get opened as well as foramen get open. I'm just going back and forth in these images, and here's the final picture of the lateral view. Again, if you look at that, you see that there's pathology in the 5S1, but again we looked at the CAT scan, and there's most likely autofusion here. That's why patient has very little or no L5 and S1 symptoms. And right after the surgery, the pain was in the leg was actually gone, and this was a very interesting encounter with the patient because right after the surgery, about 2 hours after surgery, patient has been ambulating, and the first question patient asked me is if I truly have done a surgery for him. I will try to capture it maybe tomorrow and ask the patient again and put it on internet. But this is actually a very good effect of minimal invasive surgery, even in elderly, by choosing a segmental correction rather than a total scoliosis correction, a segmental correction that addresses the clinical symptoms. And I think this has been extremely successful so far, even in elderly. And I will put the patient testimony tomorrow on the internet. Thank you.